My name's Kelli Miller, as Biz said. I'm a board-certified OBGYN. I practice in Louisville, Kentucky, where I practiced for 25 years and stopped delivering babies in April, maybe around my 4,000th baby, and just decided to pivot and, follow kind of my passion, which is that of the aging woman and menopause medicine. In my training, we probably spent 1% of our training taking care of women as they age. And I learned very well how to operate on women. My specialty is prolapse surgery and incontinence surgery. And, learned how to help women get pregnant, stay pregnant, and then deliver their baby safely. But we spend such little time in our residency training. And if you can imagine that if I spent little time in my training taking care of women as they age, the other specialties were just really far behind. And, so I started getting a lot of questions maybe 5 years ago, thanks to these minnow influencers out there getting the word out. And women were like, hey, wait, I'm suffering, help, help. I mean, the boomers especially, they're pissed because they've kind of missed out. And, so you all created this movement. You came to us and you said, hey, wait a minute, help me. No, I'm not, this isn't working. And, this movement that's happening. And so I recognized my deficiency as far as in learning and training, and started doing more coursework and content, and got certified as a national menopause certified provider. And, with VO, I've had a couple Atlanta-based people say, how do I find you here? And, there are some menopause certified experts here in Atlanta. There aren't a ton, but there are a few. And the Menopause Society website can give you links to them. But so I got certified in that. I've been spending, so I see a lot of patients now in my practice that come to me for consults for menopause. And one of the common themes that I'll hear is, I loved my OB. They delivered my babies. And that person had such an impact on them. But they're not answering my questions. They're saying, you've just got to deal with this. You've just got to, and they're like, okay, I've got to find someone else. And so that's kind of one of the takeaways is, if you feel like you're not being heard, even if you've got this great connection, find someone that will listen and can help you, because there's help out there. A couple years ago, I got board certified in obesity medicine, another one of my passions. And I'm with VO. So I've just pivoted a little bit and loving this next phase. And loving the sleep too, without delivering babies. Kind of have a 9 to 5. I joke about that, and it's wonderful. Total game changer. But so the goal today is just to help as far as I also really pride myself in evidence based. So you'll hear me say, this is what I believe. This is what the evidence says. So it's to explain as far as what the evidence says, break down myths that still exist, misconceptions, and really get the conversation going. Just a few of my kind of passions as far as big themes. One of the things is that this neurochemical shift that happens in perimenopause is huge. And we still have work to do with our 30s and 40s that are in perimenopause. So menopause, yes, having a moment. Perimenopause still needs some attention. We've got a lot of grace for big hormone shifts in our lives, right? Puberty, when our kids go through puberty, we give them so much grace. Pregnancy, postpartum, but hey, what about us? And I think just having more grace for what we do when estrogen literally dives off the cliff, leaves the room, and those changes that we experience. I love that I'm getting more men in my office. I told the Uber driver yesterday I was doing a talk on hormones, and he was like, when do you do the one for men? And I loved it. I was like, dude, this is a marketing strategy right here. We need to have one for men, and men are showing up in my office, and I love it. They're saying, I want to understand, and I love that. So this new version is emerging, coming up for air, as someone just said, which I love it. We've got to take care of our needs, not just the needs of the family. This notion that when we're no longer able to, reproduce or nurture another human, we're not useful. We step through this door to the other side, which is this wonderful journey. Sense of community, when we speak out, we're breaking that feeling of isolation. We're normalizing it by talking openly, and we're shifting this narrative from shame to strength, and I love it. We're understanding what we're going through. That creates solidarity. Collective voices, shared advocacy is going to lead to more resources and policies. With VO, what I love is that we make health a verb, not a noun. Something every day that's active. We have this perspective shift and really believe that this number on the scale doesn't serve us, but to be healthy in our body, take care of our body. Skinny is out, strength is in. We're present, we think more clearly. With peace, we're strong, fueling our body to carry us into our 50s, 60s, and beyond. We want to be strong and vital, that's the good stuff. Wired and tired of our 40s, poor 30s and 40s-year-old, that's out as we age. It's wonderful. I also love to stress that the diseases of aging, a cognitive decline, cardiovascular disease, that doesn't start at 60 or 70, right? That's starting in our 30s, 40s, 50s. Myths to try to dispel. They happen suddenly, that it's just one day, that what you're feeling, well, you're not menopause yet. It must not be menopause, right? It's a myth. It starts years before, sometimes mid-30s, late 30s with perimenopause. That it's only hot flashes. So perimenopause, well, you're not having hot flashes, therefore you can't be, this cannot be due to hormonal fluctuations. So we've got estrogen receptors all over our body. It looks more than just hot flashes, right? And I would say that's probably, when women come into my office, it's more, I don't feel great. It's the cognitive decline. I think I might be getting dementia. I'm just not present anymore. My world is this and the technicolor is gone. I think that's probably the most common reason that women will come in. Hot flashes is not just the only symptom. That it's the same for every woman. So, I had a patient the other day just talking about this burning tongue sensation she couldn't get rid of. And I'm like, okay, I have heard that a couple times. A little bit new for me, but it's not the same. So our experiences vary wildly. So the treatment is only available once you have stopped having periods for a year. Another thing that drives me crazy with perimenopause patients is that no one would bat an eye to say, hey, you want some birth control pills for all that you're going through? Why? Why do we say that? Why do we not talk about bioidentical hormone therapy? That when you look at a safety profile, way more safety data with hormone therapy than birth control pills. So you don't have to wait until you're fully menopausal before you can talk about hormone therapy. And that it's dangerous. So we're gonna get into that data in 2002 and what happened to really create this myth, but it's safe and beneficial for many women. The other thing I like to tell women is we're not just our breast, right? So this fear that hormone therapy is going to cause breast cancer, it is a myth that we have to continue to work on, and I'm not trying to discount breast cancer, so it's the number one cancer in us, so we all need to be very aware. But 1 in 5 women will get Alzheimer's, no cure. 1 in 3 will have a heart attack. 1 in 2 will die if they have that heart attack. 1 in 8 women will get breast cancer. 1 in 33 die if they get breast cancer. 1 in 2 women will suffer an osteoporotic fracture. 1 in 3 will die if they have the fracture. So cardiovascular disease, undoubtedly by far the number one killer of menopause women. And so when we think, oh, my mom had breast cancer, I'm going to go over that data. I can't take hormone therapy. Well, it sounds like your mom has a contraindication, but not you, right? There's more than breast cancer as far as with hormone therapy, and that we have to think of our heart and our brain and our bones. Perimenopause, that period leading up to menopause, we make these definitions, diagnoses in hindsight, which is just kind of silly. Menopause is 1 year without a period. That's when you're menopause. And some people are like, well, I'm done with menopause. Well, no, it's not done with you. You just have it. So we're menopausal for the rest of our lives, which, 40% of our life. Which, people when they say, oh, menopause, they're like, oh, and I'm like, let me tell you, the hard stuff's in the 40s, my experience personally. The 40s are the absolute worst. Sorry if you're in your 40s or getting there. You're juggling all these things, but then when you enter into menopause, just get help and get your team on your side because it's fantastic. We have time for ourselves, it's great. So, and we're going to spend 40% of our lives in that time period. So it's significant. But perimenopause is that transition, so 8, 10 years, mid-30s, late 30s, 40s is when we'll start kind of entering that. Irregular periods, sleep disruption, hot flashes, night sweats, mood changes. The biggest thing I hear in perimenopause is that I can't sleep. They don't usually say that, actually. Patients in perimenopause will say, I'm so tired, something's wrong. Check my numbers, I'm really tired. And then when I ask about their sleep, they're like, well, I fall asleep fine. I'm like, but do you stay asleep? Do you get that deep sleep? Do your wearable, let me know what your percent is in REM and deep sleep. And they just get terrible sleep. And so, talking about getting rid of the alcohol, which is so hard. It was one of the hardest things for me. But, just how can we optimize our sleep? There are supplements, there's nutrition changes, there's hormone therapy. So we talk a lot about that. And the mood rage too for perimenopause. Those are the 2 most common issues. They're so tired and their moods, they go from here to here like that. And they know it and they can't control it. And so the rage is real. Maybe some of you can relate. But see, in menopause, okay, here's one of the other great things. We go like this, right? So I tell women, I'm like, I'm in the gutter like with lab testing, I'm like, I'm in the gutter every day, all day, and it's wonderful. You're here, you're here, you're here, you're here. You just don't know. And that's for our brain. Our brain loves homeostasis. It likes, just steady state. It doesn't like this. And so that's why there is a biologic reason that we feel like that in perimenopause. Premature menopause before the age of 40, it's a big deal as far as the health consequences that happen from that. And so if you are a BRCA carrier, you have to have your ovaries removed early, you go through a premature menopause, big deal. So busy slide just to go over the symptoms that we experience. Again, estrogen receptors all over our body. So yes, hot flashes, night sweats, that sleep quality we've touched on. The genitourinary syndrome of menopause with vaginal dryness, burning, pain with sex, lack of libido, lack of sensation, more overactive bladder, more frequent UTIs, decreased libido. And nobody really talks about that except for me in my office all day, every day. I just try to tell women, like, I know why is it so high on their list of needs and just not ours at the end of the day? Maybe they're the ones with the problem. So lack of libido, the mood, cognitive changes we've talked about, quality of life. Another thing that I've been probably the most surprising to me that helps is the joint pain. And so when I see women back that have started estrogen therapy, they're like, hey, that pain that I've had, it's gone. Especially the hip joints. So when people talk about like their fingers, I'm like, hip joint, shoulder joints in particular, a lot of estrogen receptors there, but also just kind of muscle pain and weakness gets better with replacing estrogen because it's a potent anti-inflammatory, estrogen is in our body. So another thing, weight changes in menopause and that midsection weight gain struggle is real. So estrogen, the lack of it shifts fat to our midsection in the form of that visceral fat, which wraps around our organs, not good, leads to more inflammation, triggers fat storage, insulin resistant. We become metabolically inflexible and very insulin resistant. So body composition changes leads to an adverse lipid profile, metabolic syndrome, and then that increase in heart disease risk. So as we age, we lose skeletal muscle mass, no question, the atrophy, and that's why strength training becomes so important. And I'm always asked the question, going on hormones, am I going to get weight gain? It's scale neutral. I wish it caused weight loss. It does not. And so I just make that clear up front. But remember, the scale isn't necessarily our friend. That body composition matters, right? Like, who cares as far as the scale? Like, really thinking about what's our visceral fat like? It's going to decrease with estrogen. What's our muscle mass look like? It's going to increase with estrogen. We have a decline in our metabolic rate. Again, that skeletal muscle mass is the number one primary driver and component for our metabolic rate. And as that atrophies, that metabolic rate goes down. Our alteration in our gut microbiome, that's associated with the estrogen deficiency, which affects the absorption in our metabolism. And then the decreased physical activity. Again, in perimenopause, when we're so busy taking care of everyone else and we neglect ourselves a little bit, we tend to become more sedentary. COVID, a lot of women started working more remotely, just not moving. So all of that really plays a part. Just some examples of different types of estrogen therapy. So tried and true since the 1940s are going to be the ones, the equine estrogens, equine that comes from pregnant mare's urine, lovely. So that's going to be the Premarin. We don't really use this. It is the most studied. We primarily use a bioidentical estrogen. And when we say bioidentical, it means it's molecularly identical to what our ovaries produce. It's actually semi-synthesized from soy mostly. Comes in all different forms, oral, vaginal ring, a patch, a gel, a spray. And then vaginal estradiol, and that's going to be a vaginal administration. Vaginal estradiol can be used at any age. You can start vaginal estrogen at 80 for UTI prevention, for overactive bladder. It does not get absorbed. So when I have breast cancer patients, when I talk about estrogen, they're like, I have breast cancer. Vaginal estrogen is not systemic estrogen. It's local only. And so if you need it for pain with sex or dryness or UTIs or overactive bladder, it is a local administration and not systemic. So two different types there. Progesterone, so you've got synthetic progestins like the Provera or Agestin, and then you've got a bioidentical progesterone. We'll get into where the synthetic progestins in the Women's Health Initiative kind of got a bad rap. And so we don't really use those so much. Like, we'll use those in certain scenarios, but for hormone therapy, it's going to be that bioidentical progesterone that's got the great safety data as far as breast cancer risk. And then there's an IUD, and so if somebody like in perimenopause needs an IUD for contraception, but they need a little estrogen, so it's a common combo that I'll use that I love very much. So you've got your progestin IUD, so you don't have to worry about contraception, and then you've got a little bioidentical estrogen to help you with the other symptoms. So, so there's transdermal, like patch, vaginal ring, gels, sprays, and there's oral. The difference between the two as far as the safety, so we go with the transdermal approach, and the reason is it isn't metabolized in our liver, and therefore we are not activating clotting factors, inflammatory markers, and we're not decreasing our testosterone. So oral estrogen's totally fine if you're on it. I always tell women, when we're pregnant, our estrogen's in the thousands, and on birth control pills in the hundreds, and in hormone therapy, we shoot for 60. Our goal is 60. I'm like, oh, you're undetectable, but we got you to 60. So, oral estrogen, even though we talk about transdermal, is like the more favored route because, again, doesn't decrease our testosterone, does not increase the risk of stroke and blood clots if it's transdermal. So benefits of hormone therapy. So I put this up here, and I'm going to go through each one because I don't think we talk enough. Another misconception, myth about menopause is, when women, and some do, they just skirt through and they just do great. They don't really, they're like, no, I'm actually feeling fine. I think that we have to remember there are health benefits with hormone therapy, and a significant decrease in osteoporotic fractures, increase in bone mineral density, decrease in type 2 diabetes, decrease in insulin resistance, decrease in total cholesterol, the LDL cholesterol, triglycerides, the lipoprotein a, which is a marker we check here at VO, and that's that one that's genetically, hereditary transferred. We know estrogen decreases that, and almost nothing else does. It's powerful. So increase in our good cholesterol, decrease in visceral fat, increase in lean body muscle mass, decrease in colon cancer, 30% decrease in overall mortality. Well, and I love the skin benefits. Decrease in wrinkles. We can talk about that if anybody wants to. Like, a lot of women are asking me, can I put it on my face? Yes, all over, and I put some on my hands. Increase in collagen production for symptoms, less brain fog, hot flashes, night sweats, joint pain, wrinkles, palpitations, depressive symptoms, anxiety. I did mention that in the cognitive effects. A lot of women will say, I can't focus anymore. Good luck going back to school when you're 40s and 50s. Like, that focus is impaired. A little more anxiety symptoms. Improves libido, mental clarity, focus, sleep. Decrease in painful sex, UTIs, overactive bladder symptoms. Women feel better. So these are our FDA-approved indications. So we know the vasomotor symptoms. We know the genitourinary syndrome. We know for those women that go through a premature menopause. And that's why a lot of women will be like, oh, okay, I don't have this, I'm good. But this prevention of postmenopausal osteoporosis, everyone's a candidate and deserves the conversation, even if you're not having a lot of symptoms. What about me for that indication right there? Contraindication, someone that's had unexplained vaginal bleeding, meaning more they bleed all the time. They have frequent periods, long periods, not the spaced out periods. That's the good thing. Prior estrogen-dependent cancer, so breast, ovary, endometrial, a personal history of that. History of a heart attack and a stroke, history of blood clots, so a DVT, not a superficial clot, severe active liver disease, not just like mild fatty liver disease, and a peanut allergy, but that one can be circumvented by compounding the bioidentical progesterone. So, adverse events, surprisingly, unlike with birth control pills, because when I talk to women about hormone therapy, they're like, I just don't like birth control pills. And I'm like, okay, that's fine, I get it. Like, a lot of women don't tolerate birth control pills very well, but surprisingly with hormone therapy, very few side effects. Sometimes the periods come back, and I try to reassure women it's just like going on an IUD, going on the pill, that you may have a little bit of bleeding, it will go away. It will go away. Breast tenderness initially, a little nausea, bloating, little fluid retention, headaches. In birth control pills and women that have migraines with ARA, we don't want to do birth control pills. That's not true with hormone therapy. In fact, I've had a couple patients that have seen me from their neurologist because of these severe migraines that tend to happen cyclically, and I put them on hormone therapy just to help that fall off the cliff that our body does in perimenopause, and they get better. So that that contraindication's not there for hormone therapy. And then dizziness. Really never hear that. Okay, Women's Health Initiative. So prior to 2002, when women went through menopause, they went on hormone therapy. 50 to 60% of women did. In 2002, a study came out called the Women's Health Initiative that totally led to this estrogen-avoiding approach to women's health care that we still see. That's still, you all are probably much more in the know, but I'm telling you, the majority of women just still don't know about this. They think that estrogen causes breast cancer, and this changed the way that we practice. Not only did it change the way we practice, but the education stopped. And so now 2 decades of physicians are out there that, we just stopped talking about it. It's like, no, you don't get it. We don't want to hurt women. You don't get it. We don't talk about it. And it's still there. And it's all because of this study. It's probably the biggest disservice to humans. It was this study. So the intent and the design of the study was pretty darn good. That we knew that it helped with symptoms and alleviate suffering, and we had all this observational data that said it prevented dementia and Alzheimer's, and it helped protect our hearts. What we didn't have was this gold standard in our study world called a randomized prospective double-blind trial. So this study was started in 1991 to look at hormone therapy and does it prevent dementia and heart disease. That was the goal. So 27,000 women were included. 16,000 took both estrogen and progesterone. 10,000 took estrogen alone. So if you don't have a uterus, you don't have to have progesterone. So you can just be on estrogen. So 10,000 were on estrogen only. And so, the Premarin and Provera arm was stopped when women who were taking hormone therapy for an average of 5.6 years showed an increased risk of breast cancer, heart disease, stroke, pulmonary embolus, blood clot in your lungs. So the initial paper was published in our journal on July 17th. So literally those of us that were practicing, we knew nothing of the data until July 17th. The press was given the information on July 9th before we even had time to review the work that this group had done. And it allowed the words breast cancer, heart disease, hormones to go viral before going viral was a thing. So what the data showed was an increase in heart disease by 29%, stroke 37%, PE 98%, invasive breast cancer 24%. This sounds terrible, right? When you just look at that percentage. That's what was sensationalized. First off, so the first problem with it was that the data, especially the breast cancer data, was not even statistically significant. And if you're a data gal or a scientist, statistical significance is everything. Nothing hits the market if it's not statistically significant. Problem number one, the biggest problem. The other thing, when you look at the percentage, it's called relative risk, and that's explained as a percentage. So when the baseline risk of something actually happening is low, that relative risk sounds much worse than the absolute risk. Absolute risk is the actual chance that this bad thing is going to happen. So if we talk about strokes at 37% increased risk, that's 9 additional cases per 10,000, which is actually only a 0.09% chance that you're going to have a stroke being on hormones. Sounds less alarming, right? So second biggest issue with the study is that the average age was 63. They were a very unhealthy population. So 65 or 68% were severely overweight or obese. 50% had hypertension and 50% were smokers. Do you all think that person, 0% of the women in the study were less than 50? 0. So if you're in perimenopause, you can't even look at this data because they didn't even include one of you. Women that were 50 to 55, only 10% of women in this study were 50 to 55. So can we take data from a worst case scenario, if you will, and apply it to those of us that are going through menopause? And the answer is no. This data has been reanalyzed over the last 20 years multiple times. The type of the progesterone was a synthetic progesterone. We don't use that. And only oral estrogen was used, no transdermal estrogen. So in that 50 to 60-year-old population that were on estrogen and progesterone, when they reanalyzed the data, what they found was the exact opposite. Decrease in heart disease, decrease in dementia, decrease in mortality. So what the big takeaway now that we use is there's a critical timing and when you can start hormone therapy to really get that heart and brain protection and to promote longevity. The breast cancer risk, again, not statistically significant. One thing that did hold true in our age group was that 4 additional cases of blood clots in the leg per 10,000 with oral estrogen. Just a couple more thoughts on the Women's Health Initiative. A Yale study came out in 2013 that suggested that false information about estrogen caused thousands of needless deaths. 48,835 fewer women would have died if they'd not avoided hormone therapy between 50 and 60. There's a critical timing, best at menopause or within 10 years after their last menstrual period. Transdermal is definitely safer, no increased risk of strokes and blood clots. And in a woman with a uterus, take a bioidentical progesterone. So the next 3 sections, I did a talk for physicians a couple weeks ago in Louisville. I was asked to educate physicians, which was great. And these next few slides, they're a little bit medicine heavy, but I just kind of wanted to go over like what happens with estrogen in our brain. So lots of estrogen receptors in the brain. Endogenous estrogen is the master regulator of brain health. So estrogen in the receptor complex in our brain, it increases glucose metabolism, energy production, reduces vasoconstriction, increases blood flow, enhances neuronal growth, it reduces the beta amyloid and tau protein production, it improves neuroplasticity. So those neurologic changes that happen during estrogen deprivation or brain fog in 70% of women with the memory lapses and verbal recall, processing speed slowing, that anxiety, depressive symptoms, there is a biologic cause for this. Estrogen enhances that neuroplasticity. Alzheimer's disease affects women more than men, 5th leading cause of death, and it's not explained by women outliving men. So that's not the reason that we see more Alzheimer's. So one of the people that I follow religiously, she's got a couple great books, and so if you want more information as far as like brain and cognitive changes, Lisa Mosconi, she's a neuroscientist at Cornell, and she's done all of the research in women's brain. She wrote the XX brain, and then she wrote the Menopause brain. So she's done a lot of great work. Her books are excellent reads. Cardiovascular risk, again, this was for the cardiologist in the crowd, but basically, with estrogen, it's going to increase something called nitric oxide. What nitric oxide does to our coronary vessels is it dilates them. It also inhibits plaques and platelets from sticking to the vessels. So with menopause, as that drops and lack of estrogen, it drops, there's more vasoconstriction. So it's going to, estrogen's going to increase our HDL, that's our good cholesterol. It's going to lower the LDL, total cholesterol, the lipoprotein. And so again, with postmenopause, when the opposite of this actually happens, that lipid profile shift is more towards atherogenesis or plaque formation. So estrogen and breast cancer. So a couple of, these are some things that I talk to women about, like that are still really convinced that these two are connected, that estrogen's causing breast cancer. Since 2002, when hormone therapy plummeted, current use is at 5% right now, only 5%. So breast cancer cases, if you think like, oh, okay, there's no estrogen therapy going on, we're going to see a decline in breast cancer risk, right? Or cases. Nope. It's continued to rise 0.5% annually since 2002. During pregnancy, when our estrogen levels are so high, 10 times higher than during other periods, we don't see breast cancer in pregnancy. I mean, I've got patients with breast cancer in pregnancy, but it's very low. And again, our estrogen level in pregnancy in the thousands. If estrogen caused breast cancer, why do we see it after menopause? When women aren't using hormone therapy, as we age and we have no estrogen, why do we see risk continue to climb? I also talk to women when they're concerned about breast cancer, those that are the BMI over 25, those that are sedentary, those that drink alcohol, strong connection with breast cancer in those 3 areas. Got to look at the whole picture. So hormone therapy with breast cancer use, low. Estimates from the best data is going to be less than 1 per 1,000 women on hormone therapy. We've got to talk about the risk as far as putting the data into perspective and look at other modifiable risk factors such as alcoholic beverages, obesity, and low physical activity. Depends on the type and the use in the regimen, so that's synthetic progesterone. We've got great data that does not show any additive effect with breast cancer based on history of breast cancer, that genetic risk of breast cancer, benign breast disease, and then their personal issues. So we also have really great data that those women that are at highest risk, so those women that have BRCA1 and 2 carriers, they've got a 50 to 60% risk of breast cancer. We have studied those women extensively and those with a family history. Even before their mastectomy, when they were put on hormone therapy, they had no increased risk of breast cancer. So what this slide is just reminding us that those BRCA carriers who have the highest risk, that use of hormone therapy before their mastectomy did not negate the risk reduction. I mentioned the study that was that came out last year, November of 24, that looked at 5,500 studies in use of vaginal estrogen in breast cancer patients, those that had breast cancer, no increased risk of recurrence or mortality. When should you stop? So I get this question a lot. How long do we use it? When do we stop? You know, when you started in that great timing, that window of opportunity, you don't have to stop it at any certain age. It's not like all of a sudden at 68, your risk is too high. So you just want to constantly be looking at that risk-benefit ratio for an individual. There isn't one specific age that you have to stop it. In fact, a study of about 10 million women that were 65, half the group had used hormones for over a decade, the other half had not. That safety data and that protection to our heart and to our brain continued. So this old mantra that take the lowest dose for the shortest amount of time needs to go away. Bioidentical. You know, so a lot of women confuse compound with bioidentical. They're not the same. Really in medicine, bioidentical it's not even really a medical term. It's more kind of a marketing or media term. Now I talk about bioidentical hormones all the time. You know, in that there are FDA approved versions of bioidentical hormones that you can get covered by your insurance, that you can get, you know, they're regulated by the FDA. You know exactly what you're getting. You know exactly how much you're getting. They don't have to be compounded. The next slide's going to be on testosterone. That is one that I use compounded because of the price. So, but for estrogen and progesterone, it's bioidentical, covered by insurance. You know, you don't have to go to a hormone specialist, med spa. I don't mean to totally talk bad about them and pellets, because I think the issue was that we weren't helping women, and so women were desperate, and so they're going to different places to hormone specialists because the hormone specialist people were interested. But I also love to tell my women that hey, we're a little bit of a group that people like to monetize, meaning just remember people are making money on you. And I like all the things, don't get me wrong. But just keep that in mind, that when you're seeing med spa hormone expert, are they really an expert, number one? And then just remember you're paying a lot of money for this. So there are non-hormone options. So when I have a patient, and I have lots of them, they're just not interested. I'll talk a little bit. I like to meet people where they are. They're not interested. And so then we just pivot and we go into lifestyle. I'm a big believer, and that's what VO is so great too about, that we really talk about embrace lifestyle changes. It makes a difference in how we feel. And there are other prescriptive medications that can be helpful. Testosterone. I feel like this is a super hot topic. I feel like I got a lot of menopause questions a year or two ago in my patients, and now I'm just getting all the testosterone questions. And so increasing testosterone levels within the female physiologic range. Unfortunately, that doesn't mean the pellet testosterone range. And I tiptoe into this because I like to see where patients are with this, but then when they ask my opinion, then I just have to tell them that pellets make people feel good. It really does, and so does cocaine. You know, we get this big, I don't know, I've never done cocaine. But that's what I hear, right? You get this really big surge of testosterone, which is so great and wonderful, and then you fall off the cliff. So you get supra-physiologic. We're just not meant to be there. And I will say, and part of the reason I feel so passionate about that is that I see the consequences. I see the women that are bald. I had an orchestra singer that came in with a voice so deep, and she was like, help me. And I was like, I can't. It's irreversible. Done. And I still take care of her, and she still has a very raspy voice. I see little micro penises. Sorry. But yeah, so clitoromegaly we see with testosterone. And with testosterone, we get balding here and we get hair here. This is not a good look. But so that is with supra-physiologic doses. So with getting your testosterone into that female physiologic range can improve sexual function. in some women. And so our governing bodies, if you will, they have position statements. And, we do feel that we don't have, long-term data on testosterone, but we don't know of any adverse effects if you monitor the testosterone levels and the response. I get a lot of questions with women like, okay, what about energy and brain fog, with testosterone? That data is super conflicting. And so I'm kind of the way I practice is I like to talk about here are the risks, here are the benefits, and then you get to make your decision on what you want to do. But I just make that disclaimer I think it will help libido, but the others I don't know. And if you want to try it for 2 months, 6 months, and then evaluate your response, and we can go from there. So the reason I use a compounded testosterone, at least in the Louisville market, and I think this is pretty much all over the country, is that it's not FDA approved for women. We use it off-label. It is for men, of course. We need to make sure they have a good libido. But for us, nobody is studying us. It's not going to happen. And so, it is used off-label, but that's okay. We use a lot of things off-label, like birth control pills for cramps, right? So that's off-label use. But so we do this in medicine, and that's okay. But it's when it's not FDA approved for something, then insurance carriers are not going to cover it. So they'll cover it for men, not for us. So when a patient's like, I want the FDA approved testosterone, no problem. I'll send them into the pharmacy. They'll pay probably $500 and they get the tube for men. We don't want the men's dose. So then they have to figure out 1/10 of the men's dose is what we need. And so then they're trying to figure out how much out of this little tube to get. That's why I love the compounded versions. And I always say, it's compounded, it's not FDA regulated, but I've got my compounding pharmacy that I adore and trust. And so they will make it up to 3 to 5 milligrams per dose, and in a little Top-A-Click, and you just take that cream right off and on your inner thigh. So it's just really easy. Okay, my last 2 summary slides, and then I can't wait to hear questions. So, risk benefits need to be individualized for each patient. For the vast majority who initiate therapy in the ideal window of opportunity, benefits outweigh the risk. Not a fad. This is science, equitable healthcare for women, full stop. For women who choose not to use hormone therapy, it's okay. This knowledge of what's happening to our body is powerful because we can optimize lifestyle, exercise, nutrition, and then look at those non-hormone options. And our health is not just our reproductive health. All women should learn how to menopause so we don't have to suffer as our mothers did. Personalization and shared decision-making is key. Periodic reevaluation to determine your risk-benefit profile. We talked about the benefits, the vasomotor symptoms, the prevention of bone loss, reduction of fracture, the treatment of our genitourinary syndrome of menopause, our improved sleep, well-being, quality of life, and the absolute risk for women in that 50 to 60-year-old group or within 10 years of menopause are low. Whereas those, particularly those that are over 70 or 20 years more from menopause, the risk appear to be greater, especially that first year after starting. That fear of breast cancer is driving women and doctors' decision making when it comes to hormone therapy, and that fear is the #1 barrier to access, and that lack of access is killing women, deprives them from their osteoporosis and fracture prevention, and that risk reduction in cardiovascular disease and all-cause mortality. And it also prevents us from believing that we are suffering. Thank you, guys. Thank you. I don't know if this is what you came to hear today, but I hope that, like I had someone before say, okay, you're gonna talk about osteoporosis. And I was like, nope, but we can talk about it. Let's talk about it. So I hope I was able to answer a question. And I hope this is some value to you all, to take some takeaways that I provided. And I'm super happy to answer. I love, the best part is not me really speaking, but I love just the conversation and the questions and this community. I did a talk maybe a month ago for a place called Burn Boot Camp in Louisville. And all these women showed up and showed out, and they were just talking, and it was the most wonderful thing. So hopefully there's some questions that I can answer. Happy to field them. Yeah.
If you have, I have a pulmonary embolism and history of, or factor V.
Yeah.
So would the topical, because I saw that it doesn't, but then if you have pre-existing. Yeah,
so vaginal estrogen's totally fine. And then transdermal estrogen, so that topical estrogen, it is going to be systemic estrogen. In patients with a clotting disorder, like a lot of women with factor V Leiden will be like, oh, I can't take it. And I'm like, well, actually you can. Pulmonary embolus is a little bit different. we've got great data that transdermal estrogen does not increase the risk of stroke or PE. And so in using a teeny tiny dose, you're gonna have to have your physician on board, but it is an option for you. And you just go with that really small dose. Progesterone too, I didn't really talk about that, but like, you know, when I travel, I might forget my estrogen, but I will never forget my progesterone. Even in those women that have had a hysterectomy, when they're like, oh, I don't need that. And I'm like, you're correct. Medically, you don't have to have progesterone, but it helps so much with sleep, and it helps so much with moods, and it does zero to clotting factors. So like progesterone therapy is an option, and then that tiniest dose of a transdermal estradiol.
Okay, so if I went through VO, I'd still need like my doctor or you?
Yeah, that's a common question that we get. We're working on like, you know, and I think that we're developing some alliances where there's like a concierge, like, you know, traditionally, so VO is still in its infancy. We're almost at a year. And so we're not really like replacing your gynecologist, replacing your primary care. Although again, in the Georgia market, I don't even know if I'm supposed to say this, but I do think that is coming soon. It's coming down the pike where there will be concierge, you know, physician that can manage all the things and prescriptions for you. We also, I'm super excited just to launch like the hormone option as far as like if you wanted to see me, you know, and take it a step further as far as like managing hormone therapy, we're going to offer that as well. Yeah. Yeah. In the white.
Since you brought up the bones.
Yeah.
So I was talking to my mom yesterday, funny enough, and she's 80 and she had a hysterectomy after I was born and obviously didn't do any of the estrogen, anything. And her doctor had never really tested her bone density, and so she just got it with the new doctor, and it's awful. Like she's actually like distraught. I'm on the patch and take progesterone, so I'm feeling a little bit better about myself.
Yes.
Hesitation. Is there anything she can do? Is there anything we should do, even if we're on all that, to help our bone?
Yeah, for sure. So I love this question, talking about osteoporosis and, you know, what do we do when we've missed the window? First off, we have to be screened. Our guidelines are at 65. 65. This is terrible medicine. It's terrible. So ask your doctor. So the way we practice is between 50 and 55, you're getting your baseline. Now, if a woman's still having regular periods, I'll say, you know, a year past because we've still got estrogen and our bones are probably pretty good. But 50 to 55, within 5 years of going through menopause, you need a baseline just to see where you are. Now, if somebody has rheumatoid arthritis, if somebody has celiac disease, if someone's on steroids, a smoker, you know, people that have risk factors, you probably even need that a little bit younger for your baseline just to make sure. But there are definitely good lifestyle things that you can do. And even people, because, you know, when they read about the side effects of the medications for osteoporosis, they're like, I'm not taking that. And so then there's this education like, okay, look, this is a 1 in 10,000 risk. You're going to have this adverse event. Whereas you saw the data as far as like 1 in 2 of us without osteoporosis. So I'm banking on that one that has osteoporosis. That's going to be the one. But 1 in 2 of us will have a fracture. There's a 30% mortality in the first year from the sequelae of the fracture. And so for patients that are at osteoporosis, I talk about the lifestyle stuff that are important and that make impact. So when we talk about weight-bearing exercise, what does that mean? So the weighted vests that you see going all around Atlanta, I noticed yesterday at Chastain Park. And what I love about here is the dudes are wearing them. I was like, what's up with all these guys wearing them? Because in Louisville, the guys have not caught on yet. We're behind always. But the women definitely are out there. And I actually love this trend. And so I have my vest, and I've been wearing it for quite a while. And the way I wear it is like when I need to get a workout in and I've only got 20 minutes, like that makes my workout, bumps it up to that zone 2 as opposed to the leisure walk. Like when I talk to women about how important walking is, like walking, yes, is good to be out, but like when we're doing it for a cardiovascular, we gotta be like we're late to a meeting or something, like we gotta be getting it. The vest does that for me, but also for osteoporosis patients, so it's adding load. So the best data we have with weight-bearing exercise is actually impact therapy, is jump squats, jump rope, box jumps, obviously strength training, resistant work. And when I have like the women that are 70 and 80 and they look at me, we're not gonna be that. Meaning we're gonna be like, I'm already doing those box jumps, yes. But like right now still, I'm like, you can do it. I have a physical therapist in Louisville that I love, so find out like, because you don't wanna harm someone that has severe osteoporosis in their spine and I'm telling them to do box jumps. I don't really do that. But I do talk to them because I've met with this physical therapist a lot. Actually, when you have like spine density issues, you don't want that twisting motion. The straight on motion is actually great. Adding a weighted vest is great. So it's the twisting motion. So weight-bearing exercise, particularly jump therapy, vitamin D3 with K2, because that's actually going to help your vitamin D levels. Calcium's out as far as supplements. So you want to get calcium in your diet. Now, if somebody is totally calcium deficient, then I'll supplement them. But, it deposits in our coronary vessels and in our kidneys, so we don't really love calcium supplementation now. But vitamin D is different, so definitely do that. So the weight-bearing exercise, the strength training, medications, and there are great medications for osteoporosis. Yeah. So I didn't really talk about testing. And so with labs, you don't have to do labs. It's super trendy and, you pay money to do that. And I'm always like, I'll check your labs. That's totally fine. In perimenopause, you're all over the place. And so I tell those women, it's a snapshot. This is not the be all end all. But boy, it's so satisfying when you objectively see in perimenopause that, oh, my estrogen's undetectable. So that's really nice. You have to be off birth control pills to be tested. That will impact it. In menopause, when I see somebody that's in menopause, I'm like, well, I'm going to tell you what your labs are, but I'm happy to do them. I always do baseline testosterone. And I'm trying to catch those like PCOS patients, those patients that run high. You don't want to give somebody, or at least without just that counseling, like, hey, your testosterone's already high. So I always check baseline before we start testosterone. You don't have to do it with estrogen replacement therapy. We don't check it and somebody wants to go on a birth control pill. So we treat patients. So our data is based on symptoms and not necessarily labs. So we have in our kind of medical circles been talking more like, should we check labs? Well, it's just not what any of the data is based on. So if I have a patient that's on a transdermal estrogen and they're like, I just don't feel great, my brain's still not great, those non-responders, if you will, which there are not many of them, but there are some, I'll check their level. And then we have a goal range, 60 to 90 is where we'd like to get them. So when I check them and they're like 20, then I'm like, oh, maybe you're not on enough. But then I always start with saying, we could just increase your dose. There's a lot of doses with estrogen that you can be on. It kind of depends on where you are through the transition. When we're kind of first going through it, we need a little more. And then as we age, I'll just decrease the dose. Or someone I might like start at a really low dose and increase them slowly. But you can check labs in that scenario. How do you know if you have too much estrogen? I forgot to repeat the question. Fail. So in menopause, it's almost impossible. But nausea, headaches, breast tenderness. In perimenopause, it's possible because our brain is trying so hard to get our ovaries to kick in and get that estrogen going. And sometimes it does and sometimes it doesn't. So sometimes our brain is like, ovaries work, and then they work. And then you get that estrogen excess. So you're bloated, the fluid retention, the breast tenderness. So we see that in that early perimenopause, especially mid-perimenopause. And that's why balancing it with progesterone is so helpful. Whereas maybe they don't quite need estrogen yet, but the progesterone balance can be helpful. You can do progesterone only. Vice versa is not true. You can't just do estrogen because it stimulates our uterine lining and we need progesterone to keep it thin so we don't get uterine cancer. So if you have a uterus and you're on estrogen, you got to be on progesterone. And don't just do a cream, right? Like you've got to be on oral progesterone to protect the lining of your uterus. The opposite is true, and I do it all the time as far as, again, in early perimenopause, their issues are mood and sleep primarily. They do so great with progesterone. They respond really well. But then that mid to late perimenopause, they really start having, this brain fog and I don't feel well and I'm hot and my joints. They need estrogen. I don't care what your lab is. I don't care. And that's not how we practice. We don't practice like, you've got to be without a period for a year. Your lab has to be undetectable. What other endocrine organ do we say, wait till it dies completely before you get help? I don't care what your symptoms are. Your thyroid is still functioning, sort of. You don't get treatment. No other system do we do that. So that's where you have to advocate for yourself, or you have to find someone that will.
So for the patient that you were talking about, like the 70s, 80-year-old woman that's kind of missed
Yes.
window.
Yes.
Do you recommend, because oftentimes they no longer go to an OBGYN, and so they're going to, a geriatric doctor.
Yeah.
What do you suggest?
Yeah, well, good luck them getting that conversation. Even good luck with the gynecologist. So I never close the door as far as like, so when we get our boomers that are pissed, so those that are over 60, those that are 70s and 80s, and what do they do? First off, it depends when they're 60, 61, 62, like when was your last period? Because a lot of women will go through menopause in their mid 50s. And so then I have this same conversation that I've had today. Those particularly that are over 70 and 20 years out, so we know that we know now estrogen's great for protection with our brain and our heart, but not so much once disease is there. It can cause destabilization of plaques in our brain and heart. And so it's a nuanced conversation, but it should be a conversation. That shared decision making, at least the way I practice and the way I think that we would try to find someone, is that you give women the data, and what the risks are, and then you let them decide. So, yeah.
I have two questions. So one would be, do you recommend a collagen supplement?
Yeah.
Okay.
I love yeah. There's some data on wrinkle. Okay, I'm going back to skin. There's some data on wrinkles and skin, and I talk about joint and hair, our poor hair that gets so thin. We need all the help there, and so I do think that collagen has a little bit of data on hair, but mostly on wrinkles. So I put collagen in my morning like coffee every day. It's just an easy thing that I supplement.
Okay. And then two, tell me about this protein. We all got to get in our protein.
Yeah.
And is there a link? I feel
Yeah.
like there might be a link.
Yes. So I think some people, it's like a super lot. I think for the data for weight loss, 1.2 grams per kilo per day. That's what the data shows for weight loss, consistent data as far as like when I talk to patients about their weight. We can't outrun our fork. Exercise is important, but nutrition in the data is where it's at as far as weight loss. And we have to pay attention and really look at that. And so protein is one of those areas that, if we're getting more protein, maybe we're eating less carbohydrates or processed foods. So, 1.2 grams, but again, our skeletal muscle mass, so that resistance training and the protein intake are huge.
Okay. So it's more of since like once we get into kind of mid 40s,
Yeah.
we're holding on to weight a little more.
Yes.
So just the upping the protein
Yes.
is a way to.
And fiber. Yes. Yes, absolutely. 30 to 35 grams for fiber. Yeah.
How does peptides play in all of this?
Yeah.
Because we're hearing a lot of that.
I know. Well, that's a great question. I wish I were like the right person because I'm really curious about, more peptide therapy because I do get a lot more like questions, but I don't know. I don't have, do you all have good, Biz? I know you've got some. You're a peptide?
I like peptides.
Yeah.
Especially given, I'm about to do the Bio Health thing, so I want to figure out how to make this work for me. But peptides I'm 40, I'll be 48, and so it helped me a lot, both NAD and
Yes.
more longevity peptides
Yes.
have helped me.
Yeah.
But I mean, it's funny because people say, I'm not an expert and I'm not a doctor, but people do think peptides are just one thing.
Right.
And yes, they're in our body, but they do so many different things.
Yeah.
And they're built for so many different. So, I would just do a lot of research.
Yeah.
And, but I think it's more anecdotal
Yep.
than it is scientific, except for like the GLP ones.
Yeah, GLPs are peptides, which I love.
Exactly. Yeah.
Yes.
Yeah. I mean, I think there's some great ones out there. I
Yeah.
had a personal, wonderful experience with them, but just like to your point, a lot of weird FDA gray area.
Mm-hmm.
So.
Yeah, and again, that really be buyer beware, and because we're a sensitive population there, and I think you try to maximize, optimize like the lifestyle stuff, and then, but when a patient asks me about getting NAD, or I'm like, okay, you've tried all these things, like, and still super low energy, try it. Just make sure you're going to a person that you really trust, and yeah, in the back.
And testosterone, you touched on it a little bit. You didn't seem too confident about you seemed more positive about transdermal.
Yeah.
And I've tried them all, pellets, they were the worst thing I've ever done. I've tried transdermal and it didn't boost my testosterone.
Yeah.
And now I'm doing injections.
Okay.
What are the thoughts on injections combined with, other bioidentical?
Yeah. I think as long as you're not getting supraphysiologic, so as long as you're staying under 100. Yes. Yeah. So just not getting that, really high level where you might get side effects. And Yeah, yeah. Yeah, there's something called sex hormone binding globulin, so I always check that on patients like you just to make sure, because if that level's high, it's binding up all the testosterone and rendering. Yeah, it's a problem. So the question is vaginal estradiol, and should we just be on it? And there are 3 areas that I talk about: that pain with sex issue, the UTIs, and the overactive bladder. Those are the 3 areas that vaginal or local estrogen is going to help. You can start that at any age, so it's not like you have to start it at 50 to prevent the urosepsis at 80. So it depends on a patient's health. And if I see a 50-year-old or a 60-year-old that has no issues with either of those areas, they're like, nope, nope, and nope. I'm like, I don't really push that vaginal estrogen. Now I counsel them, that, hey, if you start having, because you probably will, more issues with UTIs, and as we age and that urosepsis, like nursing home, like everybody should be on that. Like everybody should. People that are gonna, I don't know, just like people that are susceptible to it at all should be on it for urosepsis protection. But do you really need that at 51 when you're not having any issues yet? Maybe not. But I would also make the argument that when I see prolapse patients, which I see a lot, that estrogen, just like it helps collagen production and elasticity and the health of the vagina. And, there's a difference, like, as far as the way the vagina looks and the support without estrogen. And so, if you've had babies, large babies, vaginal deliveries, and, you want to try to help prevent that, that is one thing you can do, but you can't really start it, when it's there. So, yeah. Yeah.
So I have a question, but I just did want to plug something. I am a VO member, and my mom has osteoporosis and my sister has osteoleukemia. And one of my favorite things with VO is they do the DEXA scan, and that gave me a baseline, and it gave me a big peace of mind about where my bones are, because that's probably my biggest concern.
Yeah.
But my question is, if somebody makes it through perimenopause without deciding they need hormone therapy, would you touched on this, but I just want to clarify. Once they hit menopause, you would say, go on hormone replacement therapy. It sounds like. That's that's the advice
I will go to my grave with my patch and my progesterone. Because, there are these health benefits, but I just feel so much better. It is so distressing when your brain it starts not to work as well, and you're not as sharp in the workplace, and, just how you feel. And so, yes, it's a conversation. I'm not here saying that everyone must be, but I'm loud about it because nobody has been and nobody is still. The influencers, yes, which is great because now you all have to go in and say, well, yeah, I'm not really having a lot of symptoms, but are there some benefits? Should I be on it? So I think the conversation needs to happen. I never am like, this is, because I have patients that are still like, I don't do hormones. Okay, all right. So, there's some benefits. I do a lot of handouts because in my Western medicine practice, the hamster wheel that, I'm just seeing patients so fast and much. So I always have all my handouts that I give them, like I'm in 1980, but I haven't put them over online. But yes, that is my stance. Yes.
Could you elaborate on the role of gut microbiome within menopause or hormone therapy?
Yeah, there's this estrobolome, and as our estrogen declines, and that really doesn't feed our gut microbiome. The gut microbiome, we're just still really starting that research in the infancy as far as how important it is. And so one of my little things for menopause patients and weight loss is take care of your gut microbiome. And when I counsel patients, I'm like, okay, here are all these things, and then we start to get overwhelmed by all the things that we have to do, what to exist and to be good. And so I try to say, okay, let's pick a couple things. And the gut microbiome has been one of my things where I did gut testing and saw that I was super deficient in some of the ones that produce the GLP and but fiber and feeding our gut microbiome as far as kimchi and kefir and taking care of this very important, again, that we're still working on data as far as that gut-brain connection, the weight loss piece. Did that answer your question? It's very important to take care of that.
Just point, and it's kind of adding on to her question, but I'm also on progesterone only. Can you talk a bit more about that contraindication of undiagnosed vaginal
Yes,
bleeding? 'Cause
yes.
I'm like, well, I have sporadic periods.
Yes.
Sometimes I have multiple, and sometimes I don't really want one. I think that's why she said no estrogen, and I just I don't
It-
really believe her.
You know what? It's because estrogen causes breast cancer, right? Like, why? Whereas progesterone, this is going to sound weird, but it's like the dick in the room, right? Like, nobody talks that the progesterone was actually the reason that we got that bump in estrogen. In breast cancer. Why are we blaming it on estrogen? But that's probably the reason. It's like, oh, don't give someone estrogen, they'll get breast cancer from that. That's just not true. It was the synthetic progesterone arm of the data that gave that bump in breast cancer. And so I don't understand that. As far as the contraindication, so like I saw a cardiologist called me about 3 weeks ago, and a patient that had 55-year-old bleeding every single day, not on hormones, and she has uterine cancer. So you have to rule out endometrial cancer before you start estrogen because it's an estrogen-dependent cancer. And so, but people that have spaced out periods, and once you look into that, once you say it's hormone related, like we've done an ultrasound, anatomically everything looks great. We did a biopsy, there's no hyperplasia, there's no cancer. Well then yes, estrogen's gonna help that crazy bleeding. So it needs a little workup before you just give them estrogen. Well, thank you all so much.